Welcome back. This is ER Medical Drama Critiques. My name is Dr. Taylor. I'm a full-time practicing emergency medicine physician and an Air Force flight doc. If you're tuned into my channel for the very first time, you're going to notice something very unique about this channel. And, if you've been following me along throughout this entire series, you're going to realize this is a deep dive. This is an analysis. This is a critique. This is a review. Certain episodes that I'm doing, you're also going to notice this is a step-by-step in terms of the procedure itself. We are taking a deep dive into every single episode of the PITT down to the smallest of details. Now, before we continue, all I ask is that you subscribe and share the channel. Also, don't forget to check out some of the shorts that I post, typically weekly on that. They're going to be posted on Fridays. They're going to be posted on Saturdays. These are, they're comedy. It's funny. These are based on real cases. So I have a number of them on there. So feel free to check those out. Also, between episodes 11 and 12, I'm going to be posting my first ever live reaction to Code Black. It is the pilot that I reviewed, so I'm super excited about that. Again, I'm going to post that between episodes 11 and 12 before we start hitting all the trauma lectures. Now, without waiting any longer, let's do this. We're doing Season 1, Episode 11. Let's go.
Women in labor, 10 minutes out.
All right, so obviously the big thing that happened at the end of episode 10 is that we find out Dr. Langdon was stealing patient medications, specifically benzos. Now, this next part in episode 11 picks up where we're getting a pregnant patient coming to the ER. Now, I do want to preface this OB scene by saying it is 100% not realistic. Should not have happened in the ER. That is the part that is 100% not realistic. Now, we're gonna pick apart certain things as it progresses, but overall, very disappointed. Honestly, it's probably one of the most unrealistic cases that they could have done. What you're about to watch is a horrible portrayal of how a pregnant patient this far along is handled in this ER. It is also a horrible portrayal of any OB doctor. For those OB doctors watching my critique right now, I'm gonna say this now, I'm gonna say it again later, I think more so in part 2. I'm gonna go ahead and apologize in advance on behalf of the PITT for how they portrayed you, because that is just not realistic. Again, that's gonna be more so for part 2, but I'm gonna mention it then as well. But now that I've said that, let's get on with the critique.
What are you still doing here?
I have 1 hour left on my shift. If I get home before 6, Ben, you'll know something's up.
Pretty sure the black eye is gonna give you away.
Well, sadly, it's not the first time I've gone home with a war wound from a patient.
Hey, Doc, you got a sandwich?
You know what, Earl? I could do you one better. I'm gonna order Tagari's Pizza. I think we could all use a morale boost around here.
No sandwich.
You could fold it in half New York style, just like a sandwich.
Better not be pineapple.
No pineapple, I promise not this time, okay? We good?
All right, so we always need a morale booster in the ER. Sometimes even the smallest gesture is enough. Now, I typically buy food for my entire ER staff a couple times a week, ranging from pizza to burgers to tacos, sometimes donuts, cookies. In the ER, we often get so busy, there's no lunch break. There's no breakfast, there's no lunch, there's no dinner break. You eat when you get the chance. Is it healthy all the time? Absolutely not. No way, right? 100% not. Now, you can try and eat healthy in the ER, and if you do, mad props. But when it's 2 a.m., only fast food places are open, your staff is drained, that second cardiac arrest on your shift is now in the ICU, that bed is now open. You got the waiting room down from 30 patients to 10 patients. You've only had 7 check in the last hour instead of 16 to 20 patients checking in the last hour, just lining up. You count that as a win. You quickly grab something to eat before the next mad rush comes in. At that point, you just need something in your system. One of the many hospitals I work at includes Riverview Hospital. I actually decided to do a pizza give back video to 5 entire hospitals, literally feeding everyone in 5 entire hospitals. On top of that, it was Nurses Week, so it made it even more special. But it was both urgent care and main hospitals as well. Hundreds and hundreds and hundreds of pizzas, literally becoming the largest single-day pizza delivery to a healthcare system in the state of Indiana. You can find that full video on my other YouTube channel for those wanting to take a look at it, Physicians for Wishes. Awesome video. We provided lunch and dinner to both day shift and night shift of literally the entire hospital. Like if you were present if you worked at Riverview and you were present in the hospital at that time, you got pizza. So when the ER gets overwhelmed, the staff is exhausted, right? You're almost at your breaking point, or maybe you're already at your breaking point. You're hangry, you're starving, you're doing all these things, maybe blood sugar starting to go low. Bringing a smile at that point can sometimes be just enough to get you to power through for the rest of that shift.
I say this with all the love and respect in my heart. I honestly do. Get the hell out of here.
You need me. My CT came back normal. Nasal bone just has a hairline fracture. I'm fine. Don't worry about me. I don't like it.
You sound like me. That's not a good thing.
Just let me finish my day.
Okay, I'm not gonna argue with you.
Yeah, all that knowledge and still learning. It really is impressive.
Yes, well, but could you at least keep a cold pack on it?
No problem.
I've had so much coffee, I've got to pee again. Walk with me. I also need to fill you in on something.
What?
So, Langdon is gone.
Gone? Where?
Home. I will handle his caseload. It won't fall on anybody else. And Dr. Ellis usually comes in early.
I get punched in the face and he goes in
No,
early?
it's not like that. Trust me, you do not want to be Langdon right now. You sure you're still good to stay?
Yeah. Are you?
Honestly, I'm beginning to have my doubts.
Yeah, I feel like God's trying to tell you something.
We stopped talking a long time ago.
All right, that flashback to COVID is real. This has been happening throughout the TV series, and I am so glad that the PITT is addressing it. What healthcare providers went through during COVID is something that you're never gonna forget. Certain triggers will remind you of that sadness, the crying, all the ventilators, the death, all the family discussions, the long hours, and being understaffed when one of your colleagues, gets ill and you had to pick up their shifts to help out. At the end of the day, during COVID and even now on certain shifts, you felt like you got hit by a train, right? But guess what? You had to go to work the next day and do it again and again and again, over and over again.
Yes, Langdon left. I will be covering for him. There are 2 hours left in this shift, and if you need to go, I will call somebody to come in early.
2 hours left in the shift. I can feel the traumas getting closer. For those that have been waiting for that critique, I can promise you, you're not gonna be disappointed. Again, I'll be posting my first ever live reaction of a TV medical drama, specifically Code Black, in between episode 11 and 12. So there will be, kind of a break in between that. I'm gonna continue to post those on Saturday, just like the rest of these. Again, I'm posting one video. Typically it's every other week. If it's not on Saturday, just because of how long these sometimes take to upload, I'll upload it on Sunday just to kind of give you a heads up. I have not decided how I want to do episode 12 through the rest of the season yet, if I want to do an entire episode or if I want to continue with part 1, part 2. It really depends on how much I'm critiquing because I want to include the majority of the episode. And to do that, I need to make sure I have enough pauses in between there so that YouTube and everything approves that. And so they may be much longer format videos, just to kind of give you a heads up.
Hey, we need a doctor here.
Natalie Malone, 35-year-old G3P2, 39-week pregnancy and active labor after a trauma.
I'm fine, really. It's not my first time.
All right, let's get her into trauma 2 for a quick check, and then we'll send her up to labor and delivery.
Got it.
All right, so here we find out we're getting a 35-year-old. She's a G3P2. I'll talk about that in a minute. She's 39 weeks pregnant, so full term in active labor, and this is after a spontaneous rupture of membrane, so the water broke. And then we hear, let's get her into trauma 2 for basically a quick exam. Are you kidding me? Are you kidding me? This is ridiculous. This is... Oh man, are you kidding me right now? This scene is 100% not realistic. Like, what were the writers thinking? I would argue this would not happen in any ER I've ever worked in. No OB wants their patient to deliver in the ER. Let's be honest with ourselves here. I didn't want to critique this episode because it drove me nuts. It drove me that, like, not a fan. So for starters, when EMS calls this in, they have a patient active labor, guess what? They're going to be directed to go directly to labor and delivery. They don't stop in the ER. It's not an ER patient, right? It's not an EMTALA issue. It's not any kind of issue like that. They may pass through the ER, but that's not an ER patient. Totally fake. Most hospitals have a protocol that if you are a number of weeks pregnant and you come into the ER with abdominal cramping, or there's actually a few other symptoms that you can have as well, you go directly to labor and delivery. One of the hospitals I work at, that cutoff has now been dropped even further down to 20 weeks pregnant. You're going to be directed right to labor and delivery. Now, the second thing here is the charge nurse would have known this patient was coming in via EMS and would have told EMS, literally over the iHern, please proceed directly to labor and delivery. And then they'll acknowledge that and they'll go directly to labor and delivery. EMS knows where that's at. They'll go right there. This was not a trauma. This was not a cardiac arrest. I'm not talking about that. And really the third thing with this case is the ER nurse just went along with it. I can promise you, I can tell you in real life, if a resident, for example, had this patient and stated to the ER nurse, hey, we're going to go into the trauma bay for a quick look before the labor and delivery, the nurse is going to question the resident. They're going to ask for the attending, or they're going to go get the attending, or they're going to get the charge nurse. A good ER nurse would not have brought that patient into an ER room. They actually would have said, hey, our protocol says this patient should go directly upstairs. So did the resident miss the protocol? Did everybody miss the protocol? Does this hospital not have a protocol? There's a few issues with this already, and I'm hoping you're starting to see that. And kind of the last big thing with at least this part of the case, the resident states to get her into trauma 2 for a quick look. No, don't do that. Not at all. No, you don't. You don't need to have a look. Even if you look and that baby is crowning, guess where they're going? Labor and delivery. Guess where it's only minutes away, if that, if you're moving pretty quick? Labor and delivery. You're not delivering this patient here. If you look and that baby is not crowning, for example, mom is only a few centimeters dilated, guess what? You're still going to labor and delivery. This entire scene is so fake. I almost, again, kind of what I said before, I almost don't even want to review this, but I told myself, I'm going to review this for all of you watching right now. I promise you all 15 episodes. I promise you that I'm going to go in depth on all 15 episodes. So it will happen. I will continue. But I'm going to keep showing you what's realistic and what's not, what we actually practice in the ER and what we don't. It's just, this is a very difficult scene. Now I'm going to add to that. It's much different if the patient comes in after a trauma or they come in after a cardiac arrest, because they are staying in the trauma bay. They're in the ER for the time being. That's normal. Actually, in certain situations like that, the OB team comes down in addition to the ER team. Let's say it's a trauma, it's a gunshot, it's a motor vehicle crash, right? They're staying in the ER until they are cleared from an emergent standpoint. Then they go to labor and delivery. This is a situation because she didn't need medical clearance. She should have just went to labor and delivery. But in a case like this on TV though, labor and delivery is minutes away. You're gonna see how much time they waste in this case. Seriously, watch the minutes go by and you're like, could have been there already. This patient should never have went to the ER.
Heather Collins. Nice to meet you. Justin should be here any minute. He was right behind me.
Any problems with the pregnancy?
Well, third time's a charm. Justin's pretty nervous though. This is his first time.
BP's 112/72, heart rate 84.
All right, so vitals here are relatively stable. Blood pressure and heart rate are normal. We hear this is the third pregnancy. Now, if you remember just a minute earlier, we find out the patient is a G3P2. So the G stands for gravid, or it's basically, saying how many times you've been pregnant is really what that is. The P stands for para, which indicates the amount of live births. So to say someone is G3P2, that just means that they've been pregnant 3 times and they've delivered 2 children. Now, there is more to this score. There's other numbers that go after it, but in the ER, we typically, don't state that whole thing. We're going to say G3P2, G4P2, like we're going to do that. Now, that's the easiest kind of to utilize. OB will use the rest of it. But in terms of like previous, miscarriages, previous ectopics, for example, we're just going to get the number of those. There's no reason to confuse yourself with all the numbers that follow when they do it. G3, P2, and there's a bunch of numbers that kind of follow. I'll put one of those on the screen for you. I still confuse those myself. Any of the ER docs I work with, none of them use that full score. It's just G3, P2. So an example would be, I'm calling, the obstetrician. I'm like, hey, I have a G5P1 with 2 previous ectopic pregnancies, 1 miscarriage, 1 C-section, currently 38 weeks pregnant, just arrived to the ER, like to send your guys' way. That's pretty normal. Now there's numbers that go with each of those, but we kept it simple. They kept it simple, at least in the PITT, and only kind of gave us, G3P2. So I do love that part.
Dr. Collins, can I join?
Sure.
Okay, when did the contractions start?
Yesterday. Really? My last 2 labors are very long, so I decided to wait it out this time. But then my water broke.
Natalie, I'm here. Sorry, I got a little lost.
Contraction!
Don't push, just breathe. Check her, Dr. King. Okay, good.
Dr. Collins states to check her, Dr. King. Dr. King literally just lifts the blanket and takes a look. No, don't do that. Any resident, any med student, any future doctor watch this right now. Don't do that. Like, introduce yourself at least to the patient. Like, this is crazy. At least say something here, Dr. King. Even if she just briefly introduced herself, what she was going to do, get permission. Is the patient going to give you permission? Likely, right? You're caring for their future baby, but at the same time, you're going to get permission. You're going to say, I'm going to be doing this exam. We're going to see how far, whatever you may be doing, you're going to get permission. You don't just lift the blanket and put your head underneath it. For starters, you didn't need to put your head underneath the blanket. That's so fake. Again, I don't know who the consulting physicians for this whole entire OB scene was. You're going to see in part 2 when I start talking about esophageal varices. Horribly handled case. Horrible, horrible, horrible. I can't talk about that enough. That's a potential lawsuit waiting to happen with the amount of stuff missed in the first part of that and how the PITT tried to portray it. It's almost like the same physician that did esophageal varices did the OB scene, because they're very consistent with each other. Both of them are just done horribly. And so we'll talk about that later in part 2. But getting back to this, there's no reason to just throw up the blanket and put your head in there. Like, this is crazy. Nobody does this. I can tell you this so far. I guarantee no OB was consulted when they created this episode. And if they were, I would question so many things, because this case was lacking accuracy and realism in what actually happened. How these patients are handled in the ER, it's ridiculous. Like, this is disappointing. There's no reason to put your head underneath there. There's no reason to do that at all.
We got this. I see hair. Baby's hair.
Why are we wasting time here, and where is OB? Even if we assume this hospital has no OB protocol, which means someone comes in active labor or with abdominal pain and a certain amount of weeks pregnant, goes directly to labor and delivery. With that protocol, you're not an ER patient. EMS bypasses the ER like we talked about, and they go directly to labor and delivery. If you don't have that protocol, which would be horrible, and it would be a shame on the medical director, the Department of Obstetrics and Gynecology, and the higher up hospital staff for not having that protocol, if that was the case. All it takes is one bad case. One case to go horribly wrong, and guess what? Your hospital will magically all of a sudden have an OB protocol. That I can promise you. Now, if I was doing a live reaction, I would have already guessed the reason OB was not down is because the classic thing I see in every single TV medical drama: OB was busy. They were busy with something. They couldn't come down. Do you remember back to the peritonsillar abscess bleed patient that Whitaker was calling ENT? ENT later showed up, and they actually gave a reason for why they weren't coming down. What did they say? They were in a radical neck dissection. Awesome surgery to be a part of. Great case. That's a great ENT case to do. But that's just not realistic in terms of the delay that we keep seeing in all these dramas where we're like, why isn't the specialist here? Oh, he was busy. Why isn't the specialist here? Oh, he was busy with another case, right? We always tend to hear an excuse like this in TV medical dramas. Stop already. Show us realistic medicine. Show us what actually happens. Don't make every consult too busy to come down. Like, this is ridiculous. Like, we see this all the time. How about we actually see a consult come down and evaluate the patient at the appropriate time? We keep having that delay. We had it with the abdominal pain patient that had the spider bite. Surgeon was busy in the OR. We had it with the ENT case with a radical neck dissection. Now we have it with OB. I can't remember if we had it with urology. It's probably the implied thing. But we keep seeing that over and over again, and I just don't think that's realistic. If you want to give me one of those cases, totally fine. But if on one shift you keep having the specialist busy every single time, that's just not realistic.
Natalie, you're crowning.
You were right. I waited too long. I thought I had more time.
It's okay. Just breathe.
All right, we can try and rush you upstairs to OB, but at the rate you're moving, you may end up having his baby in the elevator.
So right now we're at the almost 2-minute mark now, and she goes, we can try to rush you upstairs to OB, but at the rate you're moving, we're gonna have this baby in the elevator. No, she would have been in labor and delivery already. This patient would have went to L&D. I don't know how many times I'm gonna say this in this lecture, critique, whatever you wanna call these now, right? Because I'm literally doing a little bit of everything. It's a lecture, it's a critique, it's review. It's the only thing it's not is the live reaction, but that one's coming. But I'm gonna say this over and over again, this patient should have been in labor and delivery. Again, I should be counting how many times I've said this. But seriously, what ER doctor was behind the script of this scene? Like, this is bull. This is just not realistic. As an ER doc myself, we are going to L&D. In fact, I'm gonna come with you. A nurse will come with. If we deliver in the elevator, so be it. If the head starts delivering, we get part of it. That's okay. We're still moving to labor and delivery. It's minutes away. Now, if something happens after delivery, if there is a complication after delivery, if we need an expert, right? We're not OB experts in the ER. Do we do these? Yes, but we're not experts at this. Do you want an obstetric emergency, an example, crash C-section done for non-traumatic reasons? Very specific there, non-traumatic, because a crash C-section for traumatic reasons is a different story. That's done in the ER. A crash C-section done for non-traumatic reasons, non-cardiac arrest done in the ER, absolutely not. You do not want that done there. You want that in labor and delivery.
So what's my other option?
We deliver your baby here. Grab a BOA kit and get a baby warmer in here. Call L&D and tell them this baby is coming now.
Call labor and delivery and tell them this baby is coming now. Oh. If labor and delivery did not already know this patient was in the ER, then clearly the charge nurse, the attending, and frankly the hospital did not do their job, or there is no protocol because this is not happening here.
What do we got?
39 weeks, crowning after a SROM.
All right, so again, that SROM, so that's that spontaneous rupture of membranes, aka the water broke that we kind of talked about. And then Dr. Robbie just kind of casually walks in. That's fine. I just thought that was kind of interesting. I would have been like, why is this patient in this room? Why aren't we in labor and delivery? What's going on here? Why is she in the ER? I understand that PITT wants to portray this delivery happening here to make it exciting, but it's just not realistic. Someone may say, well, Dr. Taylor, how would you have made it exciting, but also at the same time made it realistic for the delivery to happen in the ER in a non-trauma setting? Funny you should ask. I just had this a few weeks ago. Husband speeds to the hospital, doesn't want to call EMS. Wife's in labor. There's no prenatal care. They have a multitude of other kids. History of drug use. Mom delivered half the baby in the car. The husband literally pulls up right at the ER entrance, right? Not at the EMS bay, at the entrance into the ER. Husband pulls up into the front entrance, runs in to get help. A nurse and myself run out. We assess what's going on. She's literally sitting in the front passenger seat, both legs up. And so you literally take a look, baby is half out. Deliver the rest of the baby in the car, clamp the cord, cut it, and we got both patients out and both patients went into the ER. That's realistic. That literally just happened. So there's ways to make cases like this realistic. There's ways to make this believable. If I would have changed that, you could have did the exact same situation, and they are literally coming in from the front of the bay, front of the hospital, something like that, into the ER. They were walking in, and baby's already halfway out. A little bit different situation, but there's ways to make this realistic, and this was just not it.
Hi, Mom. I'm the attending. I'm Dr. Rabinovich.
I'm Natalie, but I'm not the mom.
What's happening? You got here just in time. We're the dads. Natalie's my best friend and surrogate. We both teach fourth grade and even share a classroom.
Yeah, same room, same womb.
We've been urging her to stop saying that.
I've got the prenatal bag, and let me pull up the birthing playlist on my phone.
It's time.
Fuck Beyonce. Fuck her.
I can take this.
No. I got it.
Go, Dr. Collins.
All right, so we're at that 3-minute mark since arrival to the ER for this patient. Again, I'm gonna say this over and over again. She should have been in labor and delivery. Where is OB? In real life, OB would have already been down here. I'm glad that I'm not doing a live reaction to this. I could not handle the live reaction to this. I would just go off. I'm gonna continue this just for you all watching right now. I am doing this for you.
Natalie, good chance we'll deliver on the next contraction.
Bulb suction is ready.
Right, head is out.
Nice. Take a break. Catch your breath before the next one.
All right, I'm gonna need another big push from you. You got this.
The only reason I'm not blurring this scene is that this is not a real person here. This is a silicone model realistic birth mannequin used for teaching. In a previous episode on the MDMA overdose, the individual in the bath, I did blur that scene because that was a real person. They were showing nudity. So since this is educational, there should be no reason to blur a birth mannequin. So great job for them, utilizing this to make this look real. Like, this was really good. The reason I wanted to show that is because you kind of see what happens. You're gonna hear the word turtle sign. I'm not gonna critique that. I'm gonna leave that up to OB because I didn't agree with what exactly happens with that scene, but we'll mention that a little bit later. But certain things that they're doing, certain manipulations, I wanted you to be able to see that, and if I just blur it all, you're not gonna see any of it. So again, because it's a silicone model, it's a realistic birth mannequin, we're gonna show that. We are not going to blur that. Now, overall in these scenes, she proceeds to do bulb suction in the middle of the delivery. 100% not realistic. You have to have a reason for doing that on this delivery. I can promise you, no ER doctor is gonna be doing bulb suction like this. All the deliveries I've been a part of during medical school, residency, or as attending, none of them used bulb suction during the birth. Get that baby out. Stop bulb suctioning this patient. It's not needed. Like, what are you doing? I don't think the PITT physicians, again, are up to date on the current literature. I don't think the consulting physicians are up to date on the most current literature. I think it's starting to affect some of these TV medical dramas. Like, you don't just need a 60-year-old ER doc. You need someone that is well versed in the most up-to-date literature that's reviewing your script. You can't have a retired physician doing that. They have no reason to constantly stay up to date on the multitude of articles that are changing every single day. You need someone that's most up to date. So that's what I was questioning with this. Multiple studies have found no benefit to routine suctioning. Guidelines from the neonatal resuscitation program, in quotes, stated, against this practice, even for neonates born through meconium-stained amniotic fluid, suctioning is done because some clinicians believe it reduces the risk of aspiration, especially if there's meconium, and to stimulate breathing. But the evidence suggests that suctioning can stimulate the vagus nerve, which can lead to bradycardia. Studies have compared babies who did and who did not receive suctioning, and they found that those who received it had lower APGAR scores and oxygen saturation. Again, that is from the Journal of Perinatal Medicine, that is from the Lancet Medical Journal, that is from the Journal of Family Practice, and that is involving the neonatal resuscitation program. I'm going to put all those references on the screen for you, so check that out. Again, I would question the accuracy in this for the consulting physicians being most up to date, and this is just a bulb suction. Like, I'm just critiquing bulb suction. That's that one thing. Like, I don't understand. Now, we did go a few episodes without a comment section, so I really want to get back to that here. Every submission I do, I have to submit a copyright appeal. And I feel like some of those videos, you have the appeal, and then when that gets rejected, you have to take it even further. Rather, it's a legal team, like, you have to take it further, and that gets appealed. And so every single time, the videos eventually get approved. So again, some shorter, some longer. The one video I actually did got taken down, but it's protected under educational fair use. I had to take that a long ways up there, and finally YouTube put it back. And so I don't know why this keeps happening. I don't know if this is a YouTube issue. I don't know if this is a Warner Brothers issue and this is just an automatic thing, or they didn't expect an ER doc to be picking apart their videos. Again, while this is the most realistic, and accurate medical drama of all time, although not 100%, I don't think they, expected an ER doc to pick apart every single scene, every single procedure, and then the public is aware, oh, well, this should have been here, and that should have been there, and this should have been done. Like, I don't think they expected that. I don't know. That's what I was thinking. Otherwise, I'm like, why does this keep getting, why do I have to keep appealing this every single time? There comes a point when they're like, hey, he is 10, 11, 12, 13, 14, 15, however many videos in, if you count all the parts, and they're still hitting him with the copyright. And then, of course, you do the waiver, or you do the appeal, and it gets approved, and it gets put back. So it just keeps happening. So I'll keep submitting it. This one will get the same thing, and I'll have to appeal that. But let's go ahead and go through some comments. All right, so never been so excited to see this long-awaited video on my watch list. Yeah, so they are, I'm posting these every other week. The live reaction, I'm going to be posting that one. That is to Code Black. That's going to be between episode 11 and 12. That is my first ever live reaction. The Resident one is done. I'm making some few tweaks to that one, but I'm actually going to post Code Black first, so I really look forward to that. I think you guys are going to love that one. I genuinely love every single episode, man. Amazing work, thank you. Been refreshing your page every day to see if a new episode has dropped. Finally, thank you. I will be unsurprised if you've already received a call from the producers to be an additional consultant for the second season, or at least the third season. I know it'll be renewed for probably a long time, but I have not received that phone call or email. That would be awesome. I would absolutely say yes to that. I would absolutely, consult even from the sidelines. I would absolutely say yes. Give me your script. Let me go through it. I will pick that apart. Right? This will be 100% accurate, 100% realistic, without question. But I have not got that phone call yet. But that would be awesome. Best real ER doctor channel doing a breakdown of the PITT. No one is anywhere close to this level of detail. Great video as always. So thank you. I appreciate that. And I watch, I try to watch every single ER doc that does a review on the PITT. There's only a handful actually. And so I try to watch all of those just to kind of see how everybody else generally does it. And these videos that I do, I go so far in depth, so far in detail. They do take a long time. I do my own editing for these compared to my other channel that I have somebody that does that. I do all this on, my own editing for all these videos. So it does take a long time in between all my shifts and Air Force and things like that. So I hope you guys, love these. I'm going to keep doing this every single episode. And then of course, when season 2 hits, we're going to be doing the exact same thing as before. Every time I watch Dr. Mike react to the PITT, I think of you and I'm like, man, if only Dr. Taylor did a collab with him, I would love that. Dr. Mike, if you're watching this, if his team's watching, I would love to work with you. I've reached out a few times, sent a few emails, and I have yet to receive a call back. I always just thought it's just because the channel is too small. Hey, it's got, I think, 6,000 subscribers, if I'm not mistaken, somewhere in there. And so I just assumed it's because, hey, the channel's small. I don't know, right? I don't have millions of subscribers. And so hopefully somebody eventually sees, I would love to work with Dr. Mike. I'm so ready for the Resident critique video. It's gonna be hilarious how much you pick it apart. I picked that one apart like really bad. I picked it apart really good, but the Resident was just horrible to watch. At least the pilot was. And I'm gonna post Code Black first, and then we'll post the Resident after that. But I think it's because the Resident just annoyed me so much, that particular TV series. And just the pilot just annoyed me so much that I was like halfway through, I just turned it off. And I'm like, you know what? We're gonna start working on Code Black. I'm gonna get enough energy. I'm gonna go back to the Resident. I did that a few times before I finally finished it. I love these videos. I just finished up a month-long rotation at Shock Trauma myself and was also with Team C. Had my photo taken on the helipad just like yours. Love that. This person is responding to this because on a previous critique I had mentioned that I was part of Team C at the University of Maryland Shock Trauma. So this individual, this physician was also on the same team. So I thought that was really cool. Now back to the critique.
What do we have in here? Ivan Puglisi, 55, has experienced a day of abdominal cramps, vomiting, and diarrhea. Afebrile, tachy at 124, BP 192 over 100.
All right, so to recap at this point, we have Dr. Mohan and Whitaker seeing a 55-year-old male patient with abdominal cramps, vomiting, and diarrhea for, I think it was a day. Now, heart rate, he's tachycardic at 124. That's legit. We get a little bit excited about that. We're hoping for something really good. 96% of room air. All right, that's good. Blood pressure high, 192 over 100. All right, so something's going on here. And again, tachycardic. So as an ER doc, the differential at this point is massive. We need the history. We need a detailed history, especially if we have not seen this patient before. So the more that you don't know, the more you need to ask. I've said that a few times. And we need a complete physical exam. So you can already start thinking in your head, just over a few seconds when you see this patient, is this cardiac? Is this GI? Is this infection? Is this sepsis? Is this dissection? Like the list goes on and on. It's massive at this point. We're utilizing that history and physical exam to help narrow this down.
I'm Dr. Mohan.
I'm student Dr. Whitaker.
Nice to meet you guys. I would have called my own doctor, but I'm from New York. You two kids ever been out there?
Oh, I've never been to New York. Coming to Pittsburgh was my first time leaving Nebraska.
All right, so my critique with this scene is Dr. Mohan doesn't even bother getting the history. She heard the brief story from the nurse and she goes immediately to listening to the lungs. And I think they tried to set that up because Whitaker is going to be asking the questions. It's how they tried to do it. But interns and medical students watching, don't do this. Get your history first. Also, he is talking and she's trying to listen to the lungs. Literally, the patient is talking and she's trying to listen. When a patient is talking, any good doctor that happens to be listening to the lungs, I can promise you this. Like if let's say I come up with another question I want to ask, but I'm already at the lung part of the exam. As soon as that patient starts talking, I have to take the stethoscope and lift it off the back, or if I'm listening in the front, I have to lift it off the chest because you can't hear anything. Like, you definitely can't hear them talking, but you can't hear the lungs. Like, you have to take this off the chest and you can still hear. But again, if you're gonna make it look realistic, and you're going to talk to that patient or listen, and you're listening to lungs, like you're going to listen to the talk and you're going to listen to lungs, like take this off the chest, take this off the back. That's what's realistic here. Again, very small detail, but I told you in this channel, I am picking out everything. Am I going to miss a few things here and there just because of the level of detail? Absolutely. There's certain things I'm skipping because these videos just be hours and hours long. But I told you I am going to nitpick for realism. I'm going to nitpick for detail. We are hitting everything on the pit. All 15 episodes.
How long are you in town?
Just till Monday. My daughter's getting married. She's my baby and the only girl.
Congratulations.
Yeah, thanks. They say you're not supposed to have a favorite kid, but...
I'm an only child, so I was born the favorite. Whitaker?
Oh, youngest of 4. I'm just happy when my parents remember my name.
No, I meant, do you have any questions for the patient?
Oh,
Hey, can I just get something for the pain, you think?
As soon as we're done with this assessment, we just want to do our due diligence.
Any intestinal disease in your past? Ulcers, gallstones, general stomach ailments, surgeries?
No, nothing.
There she goes again, listening to the abdomen now. How about you ask your questions as well? Stop doing the physical exam that you're doing right now and get a history. Whitaker's doing a good job of asking questions, but there are a ton of things they didn't ask yet. So Mohan, in this case, just skipped directly to the physical exam, as I mentioned. Now, will an ER doc go right to the physical exam when seeing a patient? Sometimes, yes, but it depends on the situation. So let's say you have someone coming in on CPAP via EMS. They can't talk. They're literally guppy breathing. Respiratory distress is bad. They are in severe distress. Blood pressure is 60 to 70 systolic. Heart rate's 140. Respirations are up to 50. They're diaphoretic. They are minutes from death. You do your immediate heart and lung exam and you do a bedside ultrasound. They are in tamponade. They get an emergent bedside pericardiocentesis. After vitals stabilize, they're able to talk with you. You saved their life. Again, a different situation here. Obviously, you would not have sat there for 5 to 10 minutes asking the patient questions that was on that CPAP as they're guppy breathing. They can't talk. They're in that much distress. They need immediate treatment or they're going to die. So there's certain things that you're going to do before other things. In this case, in this patient, never been there before. They probably don't have any history. You want a detailed history and then a physical exam. So I will say on another note, it's a red flag when a patient asks for something for the pain before we've actually completed the history and physical exam. Patients often may think that we're immediately going to leave the room like mid-history or mid-physical exam, put an order in for pain meds. The nurse is going to rapidly see that order, ignoring the rest of their patients. They're rapidly going to see that order. They're going to quickly get that medication, realizing, they have a lot of patients with a lot of meds. They think that the nurse is immediately going to see that order. They're immediately going to get the meds. The nurse is immediately going to come back and administer the medication right away. And then we're going to come back in the room and continue our exam. 100% not realistic. That's not how that works. We understand you're in pain, but we need to finish our questions. We need to finish our exam. Now, I will say there are times that we have to give medications first to get a better exam. Different situation. We have a patient comes in after a trauma. They did a lot of methamphetamine. Right now, they're in full on, they're tachycardic, blood pressure's high, you know, they're having all these different symptoms, they're combative, aggressive, maybe they had some PCP in there. We're trying to assess, because this is a trauma 1, multiple injuries, we're trying to assess them, but then at the same time we can't because of how aggressive, combative. So sometimes it requires, and they're like thrashing and everything else, and so sometimes it requires medications so that then we can do our exam, and that has to do with kind of a safety thing. So again, there's a multitude of other, other reasons, but I'm specifically talking in this case about the PITT, but specifically talking about this case. But overall though, just finish the history and physical exam, in this case before you give meds. So I did like that they mentioned that, that they wanted to complete it before the meds. That was very good.
Good bowel sounds. Abdomen soft. Nothing focal.
Anything else bothering you?
My back is killing me. 4-hour car ride will do it.
So when patients come to the ER for abdominal pain, we're gonna listen with a stethoscope, but I'm gonna let you in on a little secret. We're also gonna palpate with a stethoscope, not just with our hands. So in patients with chronic abdominal pain or patients that have drug-seeking behavior, oftentimes what we're gonna notice is that doing an abdominal exam via palpating with the hands does not give the same response as palpating with a stethoscope. All right, now obviously that's not the same for every patient. Classic example would be the one I had last week. Abdominal pain at 10 out of 10, actively eating corn chips, right? They come in, abdominal pain, doc, pain's at 10 out of 10, I can't handle it, worst pain of my life. Hold on, can you just come back? I need to finish my phone call and eat my corn chips at the same time. Oh, my pain's a 10. Actually, you know what? It's a 10 and a half. No, doc, it's 11 out of 10. Worst pain of my life. But come back, I need to finish the phone call. So you're doing this exam, before you even push on their abdomen, oh doc, it hurts. You're like, I haven't even pushed yet. And you were just eating corn chips and your pain's, I don't understand what's going on. They're flinching, they're yelling right before you push. And then you take your stethoscope. They think that you're listening when really at that point you're not listening. I'm pushing with this. And you start pushing with your stethoscope and there's zero pain. They're still talking. They're eating corn chips while you're pushing with a stethoscope. We can actually push almost to the floor, if you will. Deep palpation with a stethoscope, and we elicit zero response. We're actually watching the facial expression during that palpation. So at that point, that's a benign exam for any acute emergent process. Like, we elicited zero response. And then you let the patient know that you're actually gonna, okay, I'm just gonna have a push just one more time. And then you just barely, oh doc, it hurts. And it's like, they shouldn't change. An abdominal exam should not change like that. Pain should not change based on palpating with the hands and palpating with a stethoscope. You don't magically go from 10 out of 10 or 10 and a half out of 10 or 11 out of 10. First off, the scale only goes to 10. Like 10 is you get your arm cut off. 1 is like you stub your toe. That's the score. And so you don't magically go from a 10 out of 10 flinching prior to palpation to a 0 out of 10 talking to the provider when they're doing deep palpation. Again, you're not hurting them, you're just pushing. It's a deep palpation. You're trying to elicit something. One of the surgeons I work with, to get a good abdominal exam, he will always talk with the patient during the exam. I love that. So you don't have to palpate with this. You can also palpate while talking to the patient because you're distracting them, all right? The best exam that a medical student's gonna get, the best exam that a resident's gonna get is if you can get an authentic abdominal exam while you're distracting the patient. True abdominal pain will reveal itself. You want to get the most accurate exam possible, and true pain is not going to change with distracting that patient. It will hurt regardless. So again, medical students watching this, feel free to drop a comment if you've already encountered this situation or if you've used that technique as well. I love it. Again, this is different in all patients, but I want to be clear on that. This was just one example of palpating with hands and palpating with the stethoscope on the same patient. That exam should not change. With a true pain and true ER pathology, it's going to be the same both ways.
I mean, the last time I tweaked it, I think they gave me morphine, and that worked pretty good.
All right, so we've talked about how the abdominal exam should not change. Whether you're palpating with your hands, you're palpating while talking to them, you're palpating with the stethoscope. True abdominal pain, a true, really good abdominal exam shouldn't change one versus the other. It will be the same kind of across the board. Now in this case, the patient states tweaked it and they gave me morphine. So that is another red flag, and that you see them look at each other. So while he is really starting to give off drug-seeking vibes, the real reason I pause here is because I still caution, all right, I caution those that are watching this. She did the majority of the history after the physical exam, which is backwards in this case. Now the blood pressure is elevated because of pain, possibly, all right? Is he in opiate withdrawal, and that explains the vitals and the heart rate? Maybe. But realize they still did not get a complete history on this patient. The patient had tremors and they were mildly diaphoretic. And already at this time, is this alcohol withdrawal? They can have a seizure in another few minutes. Is this opiate withdrawal? Now they do ask, if I recall, they ask about alcohol and things like that. And the patient stated no. They can kind of press this a little bit further and ask a little bit, have you ever drank alcohol? Well, yeah, occasionally I had some. Well, when you do occasionally have it, how much you drink? You get a patient sometimes that'll be like, well, I just drink a glass of wine. Turns out that glass of wine actually holds an entire bottle of wine. Now, I will say every patient that is drug seeking, will they say this? No. Will patients have a real emergency like an appendicitis that are also exhibiting drug-seeking behavior? Will they also say this? Absolutely. So just keep that in mind. Even those that are drug-seeking or appear drug-seeking can have real emergencies. Your frequent flyer with chest pain that visits multiple times a week. Be aware, one of those times could actually be a STEMI. One could be a pulmonary embolism. That frequent flyer with chronic pancreatitis, chronic abdominal pain, sooner or later is going to have something emergent. Let's say they keep getting recurrent pancreatitis and now they come in with severe abdominal pain, lactate 6, and they actually have a superior mesenteric vein thrombosis, celiac vein thrombosis, which are complications of that. So you got to keep this in your mind as an ER doc, and I think that is the benefit of a good residency program, is you're learning all these things and you're not skipping steps. So realize that even drug-seeking patients, even patients with chronic pain can have emergencies.
Do you smoke?
No.
Drink alcohol?
Once, twice a month. I'm not a big drinker.
Any recreational drugs, either pills or by injection? Tranquilizers, hallucinogens, painkillers?
All of the above. Yeah. I'm kidding. No drugs. Never.
And what do you spend your time doing?
I'm an actuary. It's risk management, stats. It's pretty much a desk job.
I pulled Zofran for the nausea.
Start with 4 repeat PRA.
What, and that's it?
For now, we're gonna start with some blood tests. We'll be back soon to check in on you.
All right, fine.
What do you think?
Big differential of pretty serious stuff to rule out.
So what's your plan?
Besides Zofran, CBC, CMP, IV fluids, morphine, maybe CT.
Good, Whitaker. Very good. Big differential. You may be thinking in the back of your head, drugs, alcohol withdrawal, but again, you still consider other things. That's why you get blood work and imaging. This is a patient new to the area, so likely you're not going to have access to his blood work, any imaging. Likely, if the patient's out of state, you're not going to be able to see those medical records, those medical charts. In some systems, you can actually see records from the surrounding hospitals. I can pull up a system. There's a way to look, okay, they were at this hospital and this hospital. I can see the labs, I can see the imaging. But in some systems, you can't see that. Now, you can ask the patient, which hospital they were just at, and you call that hospital. Ask to get put through to the ER and speak to an ER doc. You find out that the patient was there dozens of times. It's their frequent flyer at that hospital. And, the patient was just at that hospital 6 hours ago. And the patient told you, well, they didn't do anything for me. They didn't fix me at all. They didn't do anything for me. And it turns out they did blood work, they did imaging, right? They got a CBC, CMP. It was extensive workup, multiple troponins and EKG'd and CAT scanned the abdomen. Patient still had pain. They CAT scanned the chest, right? This massive extensive workup, and then found nothing. And then patient was ultimately discharged. Now, they did this extensive workup. They found nothing. They told the patient, follow up with the PCP. Well, he didn't want to follow up with the PCP. He wanted another opinion. Now, every doc is different. Things change. In the example I just gave you, we're seeing that patient 6 hours after the previous hospital saw that patient. Things change in 6 hours. So we'll call the ER, we'll see what they did, and sometimes it's good to actually have a reference, for example. So in this case, white count was 8 in this particular patient. Was seen in an outside hospital, right lower quadrant pain, CT was read as normal as an IV contrast study. You see that patient 6 hours later, still with right lower quadrant pain. that's pretty normal. What you're going to do at this point is, well, the abdominal pain is not normal, but seeing that patient persistent pain is pretty normal to get blood work. So you do that. They had a white count that was normal, that was 8. Now the white count is 19. They still have right lower quadrant pain. In this case, gave a call to general surgery. They saw the patient. Turns out that CT, when you look at it, the appendix was the upper limit of normal. So likely now, we wouldn't repeat the CAT scan, in this situation, but likely if you were to repeat it, now you'd have some periappendiceal fat stranding. Now it would be more of your appendicitis. So patient was taken to the OR. Sure enough, this was an appendicitis. In this case, in the TV medical drama, you get labs, let's say they're all normal. That's a different situation. So all of that to say, just consider the possibilities and make sure you do a detailed history and physical exam. Overall, great job to Whitaker for wanting blood work in this situation. 100% agree with it. Awesome job.
Good on labs and IV fluids, but no morphine. Treat symptoms with clonidine and muscle relaxants.
What if he's... Look, I really can't lose another patient today.
Remember how I said you get good at spotting the fakers?
Yeah.
He's exhibiting every sign of opiate withdrawal.
Eyes dilated, tearing, skin has piloerection and goosebumps, hypertension, tachycardia.
Agitation, restlessness, perspiration. He's checking every box.
Right, but he said he doesn't take drugs and seldom drinks alcohol, so that's exactly what he would want you to believe if he was drug seeking. Wow, you're good.
Thanks. I am.
So how do we treat him?
By getting him to admit his opiate usage.
Right, how do we do that?
By being smarter than the patient.
Got it.
Now, he may be exhibiting every sign of opiate withdrawal, but again, I caution the situation. Now, they never mention EKG. I would add an EKG onto that. And the reason for that is nausea, vomiting, diarrhea. What happens, if the patient has a prolonged QTC, it's not uncommon to start getting deficiencies in potassium or magnesium in these situations. So what happens, the EKG shows a prolonged QTC, it's 540, 560, 570, 580, whatever it may be, and you give them a QT prolonging agent like Zofran. The patient actually goes into a lethal arrhythmia like Torsade. So again, I would probably add on a mag level to this. I would add a few additional labs onto what he said. But overall, I thought it was good. I would just add a few things myself. Now, this is a different situation if you had someone present the same way, same vitals, but your abdominal exam was different. This was a patient that said the exact same thing. They gave me morphine last time for pain, but now you do your exam, and even with distraction, it stayed the same. Diffuse pain, even with the stethoscope. Now, something's going on here. So at that point, the patient may be in alcohol withdrawal, they may be in opiate withdrawal, but you don't want to miss the fact that that withdrawal patient now has a ruptured appendicitis. Realize patients can have more than one diagnosis. Even patients with chronic pain and those in withdrawal can have real pathology. So please keep that in mind, especially med students, future physicians, residents, anybody watching this. Realize you don't want to get narrow focused. You arrive at that first diagnosis, boom, drug seeking. And realize that patient alcohol withdrawal, they're actually having a STEMI at the same time they're in withdrawal. The patient in opiate withdrawal, they actually have a ruptured appendicitis. Patients can have multiple things going on at the same time. So I think one thing to at least carry away from this critique, you just don't want to focus on the very first diagnosis you come to and think that, that's all it could be, because you could miss something.
Shoulder dystocia.
The head's pulling back. That's called the turtle sign.
Hey, Donahue, can you call an L&D nurse and ask her to bring down a fetal monitor, please?
What's going on? Baby shoulder might be a little stuck on your pelvic bone.
It's nothing for you to worry about. We'll just try something different on the next push.
All right, so if you're having a contraction, you're pushing, the head's all the way out, and the shoulder does not want to come out, that is shoulder dystocia, literally a birth emergency, when either one or both shoulders are stuck behind the mother's pubic bone. Now, if the patient keeps pushing or you pull that shoulder, you're going to stretch that area and you're going to cause bad injuries. Now, I don't want to talk about shoulder dystocia specifically. I'm going to leave that up to any OB that reviews this particular episode, and I really hope they do. I would love to see, OB's take on this episode. I can guarantee you any OB would talk about shoulder dystocia pretty hard, so I'm going to leave that up to them on that one. But for starters, I'm not an OB, and for second, this patient would not have been in the ER anyway, right? Add that to the list of how many times I've said this. But for another issue, Dr. Robbie states to call labor and delivery and ask for a fetal monitor. Are you kidding me? Come on, producers. Who is consulting for this? Horrible. Calling you out now. I think I've called you out a few times in this episode. Just horrible. You tell me right now what a fetal monitor would do in this situation. Tell me. Nothing. Zero. It will do nothing. Absolutely nothing. This head is the head is already coming out. The baby is I can already tell you the baby's in distress. You don't need a monitor to tell you that baby's, in distress. The monitor is not going to add anything in a situation that we don't already know. Congrats, the baby is in distress. We already knew that. You just wasted time with a baby monitor. I know what we should do. We should probably get an obstetrician and gynecologist to come down here, right? We don't need a monitor to tell us that baby's in distress. Skip the monitor. How about you bring down an OB doc? You don't need a fetal monitor. That's not going to change your management. This baby is being delivered.
Ready? Why don't we all take a deep breath, huh? Everybody. One more time. Dads too. And in.
Yes, take a deep breath. I'm going to take a deep breath. I feel like I could take a few of these. Again, I'm only pausing here because this entire scene is just ridiculous. This whole birth scene is ridiculous. And, I'm working on obviously the rest of this, and just watching that, it just gets worse. And I'm going to keep calling that out. I'm just going to take another deep breath. This is my chance to really kind of air this out, just to say how ridiculous this entire scene is. Seriously, who consulted on this episode? It was clearly not an OB. I understand this is an ER medical drama on TV, but the PITT portrayed this entire birth scene horribly. In part 2, it's only going to get worse, and I'm going to be critiquing that hard.
We're moving Central 6 to Trauma 1. We need you. We are not done here.
ICU boarder, 48-year-old cirrhotic, here for hematemesis.
Intubated overnight, and after 1 minute, PRBCs and FFP was supposedly stable.
Not anymore. Weak carotid. Javati, I need you on section. Why is she bleeding all of a sudden?
Most likely bleeding is from the esophageal varices. With cirrhosis, you get enlarged veins under pressure at the entry of the stomach, varicose veins, and they can burst.
What does that mean?
The cirrhosis from the hepatitis B caused a vein to burst where the esophagus meets the stomach, and that's where the blood is coming from.